Okay, I think we're ready.
Okay, so today we're going to talk about setting standards for the results of distal hypospadias repair and how do we maintain those standards. And we've invited a pilot, he's a commercial instructor to join us, and he's fun because he's going to talk about things from his perspective. But his perspective also includes being a father. His son had hypospadias, and so he'll mention that too when we come to him. So let's just review. Let's start by looking back to the first session that we began with this question: does this boy with distal hypospadias need a repair? And we talked about the fact that it's not unusual for a family to be referred to a surgeon and go see him. And sometimes the surgeon says, no, that would just be cosmetic. We can do it, but you don't have to do it. And then they're a little puzzled because, well, wait, when the boy was born, they told us at the hospital that he might need surgery. And our pediatrician sent us to this doctor thinking he would need surgery. So then they're not sure and decide to get a second opinion. And then the second opinion gives exactly the opposite. So lots of parents have told us that how distressing, how disturbing this is. They see two specialists and get totally different opinions about whether their infant needs to have anesthesia and surgery. So to look at that question, we started out by saying, well, what are we trying to accomplish when we do hypospadias repair? And we can say that very simply. We're going to take the abnormal anatomy of hypospadias and make it into normal anatomy.
And last time, we also invited Mr. Hutton to talk about what normal anatomy is in terms of the meatus and the glands in boys without hypospadias, and we've used that as our comparator. So here's normal, which we said in a whole cohort of boys, that means glands fusion or the glands closure needs to be more than 2.5 millimeters, and the mean is 4.5 millimeters.
And so we use this as the way to determine whether somebody needs a distal repair or not. If they have normal glands fusion, despite a somewhat larger looking meatus, they don't. But if they don't have glands fusion, then we believe they do. And so the question is, well, does glands fusion really predict functional outcomes?
And that's certainly what we see in our patients and what has been reported. Abnormal anatomy increases the likelihood for abnormal function. Here's a few examples of some adult men. We had 31 in a row with uncorrected hypospadias, and 80% of them had spraying of their urine. Sometimes it was almost every time they voided. Other times it was infrequently, which in some ways made it even worse because they never knew, to predict if they were going to be spraying everywhere all over their pants and shoes or their neighbors in the urinal or not. So,
and all of these men were distal hypospadias, we stress that. And yet 80% of them had some struggles with urination on a regular basis.
But it's not just urine spraying. There are also issues with ventral or lateral curvature, which we saw in a third of the patients. There are now several new studies that we've recently seen published or have been reviewing that show that this is actually a very consistent number. About a third of patients with distal hypospadias have significant degrees of curvature. And of course, that can impact discomfort during intercourse, whether it's from the curvature itself, or we've had some men that complained about the exposed mucosa of the urethra causing discomfort. And then, of course, 40% were just bothered by the appearance of it alone, which is quite a substantial number. In addition,
right. We didn't have anybody who came to us saying, I just want to be fixed because I don't look right. Everyone had a functional problem. And in addition to that, half of them essentially pointed out that, oh, and by the way, doctor, I really don't like the way I look. So, but we're not the only ones to find that. Here's another study by Bruce Schlomer published a few years ago, where they used these diagrams for people to self-identify whether they were normal, as in A, or had hypospadias, as in the other ones. And then they gave them these
standardized questionnaires.
Yeah, to answer. And you see that they had the same response, that when they compare BCD to A, the patients who identified themselves in those categories, they found the same thing we did: penile curvature, difficulties with intercourse, problems with their urination. So that's two separate studies done in two separate ways that found the same results. So we concluded from that yes, abnormal anatomy increases the risk for abnormal function.
We also defined what abnormal anatomy as opposed to normal anatomy is in boys, giving us a marker for who needs distal hypospadias repair. And that would include somebody who has a glans closure of less than 2.5 millimeters, or more commonly none at all, and penile curvature too.
And then, we drew the conclusion from this, because it's not just the appearance, it's also functional, that we should recommend surgery for patients who have abnormal anatomy like this to make the anatomy normal. Now, when we presented all this last time, one of the people in the question and answer session after that said, well, but if we're going to recommend surgery for these boys, how do we know that the results that we're looking for are going to be obtained? And we said, that's a perfect question. We're going to answer that. Hold that thought. So today, that's what we want to discuss, and use this as the springboard to go further into it and say, well, having decided here are patients who will benefit from surgery
from a functional standpoint.
Yeah, but that's assuming that we make their anatomy normal. How often does that happen? So these are our results that we published, a decade ago on a large number of boys, and you see we had a low complication rate. And when we show this slide, we always stress that these were consecutive patients. Sometimes you read articles and it says, well, we did 400 tip repairs, but they don't say, well, but how many other types of repairs might you have done? So we didn't do any other repair. In fact, I haven't done any other repair since this, technique was published. So these were the results in distal hypospadias. That's all we're talking about is distal hypospadias. So we had good results from doing that in the gamut of patients who came in. There was no selection of patients.
But of course, we're not the only ones that can achieve this. Here's a meta-analysis of 3,600 patients from a variety of studies that show a mean complication rate of 4.5%. Happens to be around the exact same number that we have. So what it shows, when I was in my master's class and was learning about study design and how we find truth in medicine, one of the major tenets was that if you can have repeated results from different centers around the world, then you can feel much more confident that your results are true and valid. And here's a perfect example of that. Other centers doing the same technique can find the same results.
But of course, we all know that not everybody manages to do that. And this is a study from Holland in which they looked at the outcomes of their surgeons in their major centers doing and teaching hypospadias repair. They used standardized reporting forms. They took photographs. This was a very well-organized study done prospectively. The data all reported to one center, which then analyzed it. So this is reliable snapshot of 800 distal hypospadias repairs done in the Netherlands by their major surgeons in their major centers. And what you see, the dotted line is at that 5%. And we chose that because many patients tell us that the doctor said, well, distal hypospadias repair has a 95% success rate. So there you go. There's the 95% success.
Each diamond is a surgeon.
Yes.
So at that 95% rate, you see that 2 surgeons, maybe the third, are there. The rest of the surgeons in this study in the country, which means anyone doing hypospadias repair that was a certified pediatric urologist in the Netherlands, are on there, but their complication rate is significantly above that 95% rate.
Yeah, and you see, in fact, the mean is actually 20% complications. And the worst outcomes were up to over 40% complications in primary distal hypospadias repairs.
That means 1 out of 10 surgeons had complications in almost half of their patients. That obviously is something that we're trying to avoid, and that's why we're having this masterclass.
So why do some people not achieve that greater than 90% success rate? Maybe some surgeons are just better than other surgeons. And of course, we know that everything in biology makes a bell-shaped curve. So if we made a bell-shaped curve out of hypospadias surgeons, you know, the 2 standard deviations on the left would say, yeah, maybe that's somebody that shouldn't do hypospadias surgery. And on the opposite extreme might be somebody who's particularly gifted to do it. But most people are going to be right there in that middle somewhere. And that's certainly where I am. And so all those of us in there can do, it doesn't matter how hard I try, how long I do this, how much experience I have, who comes and helps me. I can never become a gifted surgeon, but I can become a better surgeon with better results inside that bell shape. So all of us can move in this direction. We just can't get to that status, but it doesn't matter because this is where we need to be. Let's look at that again in more detail.
And I think real quick, it's important to point out for our parents and families that are watching that there's really nothing in our training process or once we're out there as surgeons to help distinguish between folks on this side of the curve who shouldn't probably be doing hypospadias, the ones that are getting good results reliably or not, and then the ones who are getting good results all the time. There is no process to help define who those folks are. There's no process in any individual surgeon's practice unless they decide to look, and that is what we are really going to focus on today.
Yeah, so let's just say that those people in the Netherlands, that probably most or all of them are in this group.
But in that group, what we're saying is that
there's
you
variation.
can take that average of 20% complication rate and bump it down. And why?
So here's another explanation, not that it's a difference in the ability of the surgeon as much as it is this. And one time we were at a national meeting and we were standing at the door looking at the audience of pediatric urologists, and Andy Kirsch leaned over to me and said, you know, Warren, if there are 30 different pediatric urologists, there are 30 different tip repairs. And at the time, I thought to myself, yeah, but there's not like 30 different ways you can do that operation and get the same results. And sure enough, in our new practice, 50% of the patients who come to us have had complications after surgery by other certified pediatric urologists. And we get the op notes and read them. And this is what we see. These are technical errors for tip repair that we read in operative reports over and over. And these patients have come to us because they have a fistula or a meatal stenosis or a stricture in the urethra or a dehiscence. And this is what we read, and we can connect what we read to the complication that they have in the majority of cases. In fact, I'll encourage you, whether you're watching this now or whether you watch it on YouTube later on, to just stay here for a second and look at these and ask yourself, you know, is that something that I'm doing? Maybe I'm making a technical error like that. So this leads to one of the things we're going to do throughout this series of sessions, and we're going to define some things as really take-home lessons that are important for all of us. So right now we can say all of us, every one of us has complications. Every hypospadias surgeon has complications. But here's something that you may not have thought of. Most of these complications are because of mistakes that we make ourselves. We almost never hear that discussed at meetings. Instead, we hear all kinds of other excuses. The child was constipated, mom didn't take good care of him, the dog grabbed the catheter, all kinds of things that you can think of. But what we read in the operative reports show that surgeons are making mistakes that result in complications. So that's the bad news. That's why there's that scatter of complications over the best results, but it also means we can do better.
Right. We just said it's not about most surgeons' technical skills. It's about the techniques that they're using. And so that means we can push everybody over to better results by making fewer technical mistakes.
But of course, we have to ask, well, why do we make so many mistakes?
Yeah.
And by far, the number one reason is right there, because we were taught them by our mentors. Our mentors probably were taught them by their mentors. And this is the problem. And so those of you who are watching, particularly who are in fellowship right now, really need to look at that and ask yourself, am I being taught technical errors right now? And we know that because of these articles which have been written about learning curves. So this is kind of interesting. There are 3 papers which have been published which said there was a learning curve after the person left fellowship and went into practice. So we took their graphs and said, let's see how many cases you would have to do according to their experience for, published here, to get down to less than 10% complications. That wasn't the point of their article, but we can use the data to ask that. And look at the numbers. Up to over 300 cases to get down to that less than 10% complications. Again, are these surgeons who shouldn't be doing hypospadias? Well, they got better with time.
Good results.
They could, but they weren't achieving the best results, or at least it was going to take them many cases to do that.
300 cases is, for many people, entire lifetime, right? But that's different than 2 other reports where there was no learning curve that was shown. That was something that I published with not just me, but consecutive fellows from the program where we trained under Dr. Snodgrass. It was a couple fellows before me. It was a handful of fellows after me. And what it showed was that for distal hypospadias repair, we could all achieve the same results that Dr. Snodgrass achieved on his own without having this learning curve.
This was all at the same time. I mean, these were cases done at this period of time compared to my results. And so we're looking exact same time.
2-year period.
And the results were all the same. And so here we have 3 series that say there is a learning curve and 2 that say there isn't. How can this be? Well, again, if you were taught a mistake and it's causing a complication, you're going to continue to have problems with that until you correct that mistake. And how long it takes you to do that becomes your learning curve, unless you weren't taught a mistake in the first place, or unless you recognize this and start looking through your technique to find things that might be wrong. And then there's some other things that play into this. For example, if you're making a mistake, perhaps it is more likely to occur in some anatomy than in other anatomy. A deep groove versus a flatter groove, for example. It's not the groove that's the problem, it's the technique variance that you're doing that causes it. And all of this, she said this just a minute ago, when you think of having to do over 100 cases, over 200 or over 300 cases before you come down into that range that can be achieved, this is data from the Board of Urology that certified pediatric urologists do a median of 12 cases a year.
Of distal hypospadias.
Yeah, and
That's
so
one a month.
one a month, and you've got to do over 100. Well, there's 10 years to achieve that. Surely we can do better than that. And then there's also this, maybe because people don't do so many, that they feel more comfortable, their mentor they admired, so they continue to do what they were taught. Sometimes even when we go to a workshop and we say, this is a mistake and this causes problems, people listening still go, yeah, but I don't know. I don't know if I'm ready to change something. So that's what that looks like. And we couch it though in different terms, don't we? So in many articles, you'll read that one of the factors that determines outcomes is the experience of the surgeon, which really is, I'm doing this, it works for me. And we've written that and kind of accepted this idea that, well, you can do it this way and I can do it. There are 30 different ways to do a tip repair if you have 30 different surgeons. That's what this is. And does it really, can you really get a good result with 30 different ways, or does it need to be done in a certain way? So that's, again, the message that the question that we're raising and the message that we're trying to bring in this session. Because this is a problem.
Yeah, it so much boils down to, I think, a couple different issues. One is, well, my mentor is fabulous. I just spent however many years training under him or her and was told how fabulous they were on a regular basis. So a pride in your training institution, or a personal pride. Well, I'm good at what I do, and so I can just do whatever I want because it's how I learned it and it's easy and I feel comfortable with that.
Yeah, and this also extends from the individual surgeon into our programs. And so we've decided to depict the programs, around the country with these different pictures of castles. The idea of this is our fiefdom, we have walls around it. And so you've even read articles that say, well, the Dallas way is to do this, or, other centers like that. And so we have this institutional pride that says, well, we're a flat place and this is what we do, for example. So pride at the bottom, reluctance to change, and then a pride that, well, I'm a good surgeon and my results are as good as anybody else's, is, we think, part of the reason why we see the results that we showed earlier. And all of that leads to this. I'll tell you that I have flown a lot on airplanes, and many of you watching have too. And I just wonder, have any of y'all ever Googled your pilot before you booked your reservation? I will tell you that I never have. And I've thought about that, getting on and off the plane, and they're sitting up there in the cockpit, doing whatever they're doing. And I've thought, these guys have to be in some ways a lot like surgeons. I mean, they're different people, and some of them are just going to be better at something than others are going to be. And yet we never Google them. Would you go have surgery from a surgeon without doing a little research into that surgeon? I bet none of you would. And yet nobody ever Googles a pilot. It seems ludicrous to even talk about it. But they would have this same sort of thing, wouldn't they? That there would be some people who want to be pilots, and it was found out somewhere along the way that, nope, you just probably shouldn't be a pilot.
Hopefully not the really hard way.
Yeah. And then there's a few gifted people. I think everyone that saw that their good fortune to have a unbelievably talented pilot. Maybe not. Maybe that's just something that another pilot could do too. Who knows? But most pilots, just like most surgeons, are right in here. And yet we all get on planes without Googling them, without worrying about it.
In
So,
fact, when we book a flight, we're more worried about cost and whether it's a convenient time and what airline it is based on what frequent flyers we have or what happens to be near our city. We never really think about which airline or which particular pilot and what their safety record is. I mean, it's just something that has become so automatic that I can tell you it's never crossed my mind whenever I've booked a flight.
So that brings us to our guest today, Michael Clifford, who, again, as we've already said, is a commercial pilot and a flight instructor and the father of a son with hypospadias. And we invited him to be on this Zoom today, but his schedule is...
Well, just like doctors, pilots are on call too. And so fortunately, we pre-recorded things just in case, and this is what we're going to watch today.
So this is him.
All right, hold on. We're going to work on the volume here for just a second. This is the tricky part of videos.
His viewpoint from his profession in contrast in comparison to ours. So one thing we were curious about is there's a lot of different pilots and a lot of different airlines, and you have to too, just like we have to train. So is there a set curriculum? Does each airline have their own training? How does that work?
So it also with the FAA has a set curriculum of times that you have to meet to be able to get that license to be able to go fly for the airline. So even before you get there, the FAA says, hey, you need to have at least 1,500 hours to get your airline transport pilot license. So you always have that going, but once you get that, that's when you can get into your airline side of things, and they have their set of curriculum that you go with and learn off that.
That's set by the FAA.
Yes, so the airline will take their curriculum and also still submit it to the FAA, and they have to approve it to say, yes, this is good, this follows our guidelines, you've covered everything in it.
So there can be some variation between one airline and the other, but at the end of the day, everyone gets the same basic training. Is that
yeah? So from your American, your Delta, you're not going to be to left field, right field. They're going to be right there in, I guess, center field. I guess I'm going to do a baseball analogy with it.
There you go.
They'll all mesh together to where if you were to leave one to go the other, you're not going to be, falling back in class or anything. They're all going to be along the same line, same training. They may have one thing that might be step 9, and at American, it might be step 4, but you're still going to be able to cover the same basis.
So that means if the frequent flyer program, I get mad at it at American and decide I'm going to fly Delta, that I'm not going to really tell any difference as far as the safety and the performance of the pilot.
No, what they do in the front office is, with the points, that's their own deal. Pilot side of it, you'll be able to rest assured that, you're going to have pretty much the exact same training from an American, Delta, or United.
So how does it work? And, we talked a little bit before how surgeons have different personalities and different innate skills, and pilots are people too. So some guys, I'm just going to guess, kind of have a different feel for it than other people. But when it's all said and done, they all have to perform in the same standard, or do some people just not get there because they can't be reined in, or how do you deal with different personalities?
Yeah, and everybody has a different personality, and it comes across in flying. I'll fly with somebody that does not like to talk. You'll sit there, you'll talk, ramble, and they'll say nothing. But the moment it comes to doing anything, both of us are trained to the exact same standards to where we know, all right, this phase of flight on our descent, we go to our descent checklist and we just kick it back up. You know, the personality side of things goes out the window. You know, while you're cruising, yeah, you sit there and talk and you get to know each other. But when it comes to the high activity areas of flying, the training is the exact same and you are held to a certain standard. And like you were asking, if that person didn't necessarily do too well on that training side, they might not make it through it or get extra training if need be.
What happens when you're all done with training and you're out? You know, it's one thing to perform under the glare of your instructors and another thing to do the right thing day to day on the outside. How does that work?
Well, once you get done with the training, you go through, you know, you get out of the sim and you're sigh of relief, but then you start what is called IOE to hold the line, and you go in and you fly with another check airman. And like I'm guessing you're asking is, you know, you'll be flying with somebody and there are days where you just start kind of getting lazy with things. But then you have to remember that you have a lot of people's lives in your hands and you have to reel it back in and say, you know what, we're going to stay with, let's do the checklist all the way through. Don't skimp on anything.
Okay. And what happens, like when I'm flying, sometimes that plane hits really hard, and sometimes even the luggage rack thing will pop open and something can fall out. Is that a demerit to the pilot? Is that a mistake, or what happens with that?
So if something like that, let's say you're having bad landings, you weren't doing the proper procedures, following a certain checklist, in between your sim trainings, you can get a line check. So say I went out and I was skipping around on my checklist, wasn't doing them. I was bouncing the plane down the runway, you know, anywhere from other pilots, flight attendants, or even passengers, you know, start complaining, and that gets back to the higher ups. They could come out and do what's called a line check. And in between my two sim training or my sims, I could come out and they just test me and say, hey, we've gotten some reviews. We want to just make sure you're up to snuff on everything. And if I'm not, then I go get either retrained or, you know, you could possibly get fired.
So tell me how often the sim training happens. That you're talking about the simulators and kind of what is involved in that process.
So every 6 months for a captain, you go back and you do sim training, and they put you in a simulator for 3 days. Then at the end, you have a check ride, and that's just basically going from takeoff, touchdown, throwing engine failures at you, any type of an emergency, just making sure you're following proper procedures. So every captain is every 6 months, and then every right seater, first officer is every year.
Wow, so a 3-day instructional, like actual
It sounds
test.
grueling to me.
Every 6 months.
Yeah, usually they block you off for a week, and you go in, do all your because you also sit in ground school, so you're making sure that it's an overview because it's not your initial, but you know they go back through systems, so your landing gear, flap system, your engines, oxygen system, everything, because you know that the piece of equipment you're on, you need to know from tip to toe on it what it's all about. So you're not only are you doing sims, you also sit in ground school for two days or so, and then you go over to the sims. And at the end of all this, you do take a written test, and then you also do sim training as well for a check ride.
I'm guessing they make that test different every 6 months, or
well,
kinda.
Yeah, it'll be reworded a little different, but for the most part, it's pretty consistent. I mean, because that's the thing, there's nothing that can really change on the plane.
Right.
You know, the oxygen system is the oxygen system. You either know it or you don't. And if you don't, that's the thing. It comes out and shows that you do not know the system.
And so this sim is like plane specific. It sounds like it's not airline specific. So it's a particular plane that you're qualifying for. Is that right?
Yeah. So most of the time, you know, at your major airlines, your regional airlines, you're not going to be bouncing from different planes. You are that plane that you're on is the plane you fly until you get upgraded to a different piece of equipment. So if you're flying a 737, you go fly a 737 sim. You don't go fly a Airbus, A320. So you're specific to that airplane until you get upgraded to a 777.
And then I presume there's a whole different training course that you would go through for your initial.
From there, you start from ground one or step one. I'm sorry. You go to step one all the way. It starts with your initial, like I was just saying, and usually your initial is 2 weeks. And then you have about a week to a week and a half of sims. And it's the exact same process. So brand new plane, brand new training.
So if I was summarizing that from our viewpoint, looking at surgical training and all of that, what we don't have are established standards. That if you do hypospadias surgery, you should have success defined as XYZ in a certain number of patients, and then have the curriculum geared to giving you that skill set to where you will get that, and then periodically reviewing that same curriculum to say, remember, you do it this way, or if you encounter this in surgery, this is the emergency, if it's bleeding, this is what you do. So we have periodic testing, but it's more knowledge-based and not skill-based, not this idea of here's your performance standard and you have to always be in that standard.
Yeah, so I guess to follow off on that, what my side of the training with that, when there's, I guess, blood coming out, well, I'll just say, okay, the oxygen system. I had an emergency light go off the other day, and the first thing for that is oxygen mask on and then the mic switch. So that's something that I feel is very beneficial because, when the autopilot's on and you're at 30,000 feet, you're just sitting there talking and, catching up on everything. And then, but once that red light comes on, those are your memory items to where you have to go and both of us are on the same page. I can't be on one and my co-pilot be on the other because, that's when things start going awry where you're pulling something where I need to be doing something over here that counteracts it. Right. So that is a big part of what we do is making sure both of us know the emergency procedures and being on the same page. And it's the training.
So what happens when a plane crashes? How does that still have, is it the plane fails then, or despite all this, do you still have errors?
Don't quote me on this, but there's statistics and it's on the FAA's website. I want to say it's 85 to 95%, somewhere in there. And it might be the higher of the 95%. 95% of plane crashes in just general aviation. Not your airlines, because as we're talking, the training that goes into it, but your GA people, a lot of the times they don't have the training, or you get a pilot's license at 40 hours and I was one of them. You start thinking you know a lot more than you do, and you get a little hot for your britches, and that's when it starts biting you. So the crashes that you see are a lot of just general aviation. Most of the time, no checklist. It's scary of how much the crashes could be avoided.
Those would be classified as pilot error
pilot error, yeah. That's what I was just about to say, that about 90 and 95%, I would say, are pilot error. Very rarely, now it does happen, is it mechanical. A lot of the time it's, I think just this past 2 weeks or so, I've seen 3 gear up landings just of people forgot to put their gear down.
Oops.
Yeah. The insurance company's going to love that one.
Yeah. So, I mean, you had alluded to it when you talk about GA, you're talking about people like doctors that go out and get their pilot's license and fly from time to time are more likely to make a mistake than the guy that's doing that every day for the airline.
Yes, because y'all know firsthand, being a doctor, that's y'all's primary means of living. So you have to be top notch on that. And a lot of the times, sometimes the flying aspect of things gets on the back burner. When I was instructing, I'd have people come in constantly, man, life happens. You have a baby, you get fired from work, you got to go get a new job. So, life happens, people take breaks, but a lot of the times the flying for the general side of things, it's second nature. It's not your first one.
Right.
So there's things that could be avoided, and
Yeah. So now that you've seen, so we've been listening to you giving your perspective as a pilot to how training and performance works, but now as a dad whose son had hypospadias, tell the other surgeons that are on here, your observations of surgeons as a pilot.
So pretty much when I first went to Snodgrass, verbatim, what happened to us, he told us. He goes, let me guess. Doctor told you he had it. You went somewhere, they didn't have it. Went to a different one. They said they could fix it. And there was just so much uncertainty through all of this. And when we left the hospital, they said, here, we're going to send you to a specialist. Okay, you hear the word specialist, you go, they know exactly what they're talking about. They do this all the time. We went to that doctor at a very good children's hospital, and he said, oh, no, he doesn't have it. It's just an underdeveloped foreskin. I can fix that, and we'll get a surgery date scheduled. Well, we weren't too confident on that. We're like, well, they are the doctors, but let's get a different opinion. And when we went to Dr. Snodgrass, he was like, yeah, he has a very mild case of it, but he does have it. And after Dr. Snodgrass asked me to do this, I started thinking about the comparison of a pilot to a surgeon. Well, where I'm putting, here's my, I think he was 5-6 months at the time, toddler, in a stranger's hands, in hope that he's well trained, that he knows what he's doing. And, there's so much trust that goes into it, just like in a pilot, where you get on an airplane and everybody's got something in the back of their head, but most of the time you're like, all right, I'm gonna get from A to B and get to where I need to go. That's, I think, what scared me the most was that I was about to, but before seeing Dr. Snodgrass, I was about to hand my child over to somebody that could have just completely butchered him and not done anything for him, but hurt him. So this was a very big eye opener for my wife and I, whenever we discovered that, pretty much anybody could just say, well, I can fix it. Yeah, we'll do it. No problem. Well, that wasn't so much the case. And, I'm very glad we got the Dr. Snodgrass's opinion.
Yeah, so I think that's kind of the point that we're hoping to make in this first session that we're offering to people, is that idea that we need to perform to a standard, and that a patient who goes to one pediatric urologist and then decides for some reason to see another pediatric urologist should really hear pretty much the same story. Just like when we book our airline tickets, we know we're going to get pretty much the same experience, because that's what your agreement is. If I buy a ticket to fly to Boston, I expect the plane to go to Boston. If you bring your son in, you expect this two surgeons to say yes or no, he needs surgery, and if he does, here's how we do it, and here's what the outcome should be.
I mean, it's an anatomy issue, yes. Right? That there's defined normal anatomy that we know what these measurements should be. And then there are boys who are born with those, things that are outside of a normal realm. And so it's not asking for this huge subjective thing, like when you go to a plastic, cosmetic surgeon, well, your lips could be a little more full or a little less full. I mean, that's a different story, right? But if you go in with a cleft lip, then everyone can look at that and say, okay, that's not right. You have a big slash up and down your lip, and here's how we fix it. And we do it at this age, ideally, and here's the team that's going to be involved with that. And we just, at least to this date, don't have that universally. Of course, Dr. Snodgrass and I do, because this is what we do, but we're hoping that other folks will kind of take this experience and know that we can do better. Other professions take people of a huge variety of backgrounds and personalities and, just everything that's different about people. And they use that to their advantage to say some people are going to be quieter and some people are going to be talky, but it doesn't matter because we're all trained so well that the moment a light goes off, say, and there's a warning, we all know exactly what to do. And it would be really wonderful if we can get to that as a profession as surgeons.
Yes.
Well, thank you so much for meeting with us and sharing your experiences and information, because I think it does give us a good platform to look at our own profession from. So thank you for that, and we'll see you again.
I appreciate y'all having me and let me ramble a little bit and get to talk about flying.
Yeah, okay, good. Take care.
Y'all take care.
Okay.
All right, so we really appreciate Michael spending his time with us to do that. And now we want to take that analogy a little step further, I think. Yeah, so we're just going to summarize, on one slide, the key points that he said. So, when somebody begins their training to be an airline pilot, they are trained to achieve standard performance. And you heard him say that the training program has to be certified by the FAA. So all pilots, no matter where they train, get the same training. They're taught the best way, not just some way, but the best known way to fly the plane and to respond to unexpected, events. And then they're drilled on that again and again until it just is an innate nature of them. He told us on a different time that wasn't recorded that he was once chatting with the co-pilot who he had never met before, and they were just chatting, and all of a sudden a warning light came on, and he said in an instant he reached over as the pilot and started flipping the correct switches, and the co-pilot, who he'd never met before, didn't know at all, reached over and started doing the exact same things that he was supposed to do because they were trained to do it that way. But then the other thing that he talked about was trained to keep those standards. They couldn't let their skills lapse. I mean, think about it. Every time we hear about a flight crashing, that's a big deal. We hear about it, and then there's a big review, right? And sometimes those standards have to be changed. Wow, this was an issue with the flaps that we didn't know about. And now that is re-drilled into them, whether it's the same things that are getting reinforced that need to continue to happen, or if a minor change needs to take place to continue with improvements. So after they're done training, you heard him say, if you're a captain, twice a year, you have a 3-day simulation all day long, them throwing everything that can happen at you. And then you go fly with the person, just the two of you, to check on your performance. If you're a co-pilot, you do that once a year, forever. And so they're periodically checking. They've defined what a pilot should do, then they check to make sure you're still doing it. And as Dr. Bush just said, if something goes wrong, they look into it and try to find out, why did this happen and what can we do to stop it? And as Michael said, when you book a flight, you expect, no matter who the pilot is, no matter which airline it is, you expect things like this to happen. So there's the box of performance that, as the flying public, we expect the airlines to provide. It does help to go to the right city. Yeah. And you heard him say that most crashes are mistakes that pilots make. Just like we said earlier, most complications in hypospadias surgery are mistakes that the surgeon makes.
the difference is that if you look at commercial airline crashes, they just don't happen very often. There's a lot of complications from hypospadias surgery, but not many planes crash. And so the point of all of this is that all these things that we reviewed and that he said to us is what makes flying safe, where we don't have to Google our pilot. And unfortunately, we cannot say the same thing about hypospadias surgery. It's a fact that hypospadias surgery causes more harm to children than any other surgery that we do. And so we got to ask that question too. Why is that? And we can simply say, she said it a moment ago too, we don't have a standardized training and we don't have a standardized update to make sure that all the surgeons doing hypospadias surgery around the world are getting the same information and reviewing it. We don't have standards. I mean, is it okay that one person has success in over 90%, another surgeon, the average surgeon, has success in 20%. I mean, is that okay, or is it not okay?
Take it even a step further. You have two different surgeons who one may call something a complication like glands dehiscence, and a whole bunch of others don't call it a complication at all. They think it's fine. So we're not even talking about the standards that we should be achieving. We're even at the point where we've got to define what a successful flight is.
And nobody reviews any of this. Most side of the surgeons themselves review their performance. And that's how we get this. So I have no doubt that the surgeons above that red line could move down, at least down to this line, the 10% or greater success, or fewer complications, 90+% success rate. These surgeons could do better if we had this concept in mind.
So let's define that for hypospadias. It shouldn't be that hard. That's why we spent our last talk defining what normal anatomy is, because that's what we're going to use for our definition for a successful distal hypospadias repair. There needs to be a meatus that looks like a slit, like most boys without hypospadias. There should be a normal extent of glans fusion. Those scars shouldn't be big divots missing out of the glands and chunks of things missing. They should be concealed in natural lines, like the up and down line of the median raphe that guys have, or a circumcision line, if that's what's normal in that kids' culture. And so that brings us to, they should be able to have a circumcision or a foreskin reconstruction based on what the family requests, and no complications. That we should be able to achieve in at least 90% of boys. That's what we're throwing down the gauntlet for, to say, if you're outside of this box, let's work on that these are reasonable goals and that they are achievable, but not everyone does achieve them.
And here are the reasons why. Again, to do it, you have to use the best technique, not just any technique, or not, well, I'm comfortable with how I was taught, but techniques are not all the same. So we have to use the best one that gives us those results. And then we have to do the steps in that operation in the best way. Again, that may not be the way you were taught. It may not be the way that you're practicing, but to get the best results, you have to do the key steps in the best way. And then we all have to look at our results and see, I mean, how do you know what your current results are? And if you review them and you see that maybe they're not so good and you make changes, you've got to look at that again to see, have I achieved those results? If you look at your results and they are good, you still would benefit from looking at them again from time to time, just to make sure that nothing has crept into your practice that is changing for the worst. And many of you have heard me talk about this for a long time. I'm just going to say it again. This is what it comes down to. You don't have to prospectively record your results. It just makes it easier and more accurate. But just looking at your results, and if you're in that 90+% success rate, good. Whatever you're doing, good. But if you're not, then you need to look at how you're doing every step of the operation, or if you're even doing the best operation, and say, okay, here's an area that I maybe need to improve, and then make the change so that your results will get better.
And you can do this through every step of the process. So we're talking about doing this for distal hypospadias repair, but maybe if you're in that 95% success rate and things look good, now maybe you want to do an improvement process for how many phone calls you get from mom to make your life better so that you don't have to answer those phone calls, but also so that you're providing the best educational materials that you can for these families. We don't have to limit this to just one process. We can expand it, and that's what we do day in and day out. What are we doing that we could get better at? But start small, start simple, and this is an easy way to do it. A few minutes of data recording when you see the patient, when you operate on them, and then when they come back for follow-up in clinic. And it really can be life-changing as a surgeon to see these direct results of technical changes that you make result in something better for your families that you're helping.
So if we kind of close with a last picture to put in mind, if we flew planes the way we do hypospadias, I think the skies might look somewhat chaotic there. And what we really need to do is learn to do hypospadias the way pilots fly planes, to bring more order and more uniformity to it so that we can all get the best results. That's the goal. So let's just summarize what we've said today. Let's agree from that data from the Dutch study that there are too many complications after distal repairs. And we will second that by saying we see complications after distal repairs constantly. And again, they're usually technical errors. So that's something that, again, is a new thought for many of you watching. Others in the past have taught different reasons why mistakes or why complications happen. But this is the number one reason that we see over and over. And so again, we've said many times, we are all making mistakes. We can all get better.
So this is one of the first steps that we could think of to help with that process. But as always, you can email us. You can join our hypospadiology email group where we present interesting cases and lots of folks chime in on those. Of course, we also have our YouTube channel that you can find under the Hypospadia Specialty Center channel. This will go on there and you can rewatch it if you have any questions about things. And we're really looking forward to breaking things down into little nitty-gritty pieces to help in this process of making a technical change and showing that it can help your patients. And so
here's our next class. You see the date next month. We're trying to do these on a Saturday once a month. And we're going to go the next step and talk about distal tip. It's the most common operation done for distal hypospadias worldwide. And we're going to talk in detail about how to do it right. And we're also going to talk again about not doing it the wrong way. So, look for that. You can tune in and watch live as we talk about it, or all of these will go onto that YouTube channel that we mentioned.
But we love to have you live, because then if we didn't explain something clearly,
You can ask.
you can ask us. And when it comes to technical details, I think there are a lot of folks who've been told something the exact opposite when it comes to tip repair than what he's
We
done,
do.
that we've done, our entire time that we've done tip. And so it's always fascinating when we have visitors here in the center that are like, I was told something totally different. And so we suspect we're going to see some of that. And we want to be able to help, things become crystal clear in your mind how we do it, so that, hopefully you can achieve that 90+% success when it comes to the boys that you deal with distal hypospadias.
We have some questions to answer.
Let's look here.
So the first person is making the observation that airplane crashes do have a mechanical error. Would we consider individual variations in tissue, blood supply, et cetera, causing trouble, causing complications, even though the surgeon has done his best effort and skill? And the answer is, we have given this a lot of thought, because in our own practice, every time we see a complication, the first question we ask ourselves is, did we make a mistake? We take photographs before and after every single repair we do. Of course, we have operative notes. We keep detailed data in our spreadsheet, our database. And so we sit down and we go through all of that. And sometimes we just come up with, we don't know why this happened. And there are definitely some factors. And we know this because of boys who get reoperations, because everyone finds more complications in redo surgery than they did in primary surgery. And why does that happen? And we published before that has to do with vascularity. And then we've shown that hyperbaric oxygen, for example, improves vascularity. I know you've been thinking a lot about just innate healing, and
we do think there are differences, really is what the answer boils down to. But now we're talking, okay, so with pilot error, it was 95% of crashes. You've got mechanical failure in 5%. I think those numbers would hold pretty accurate when it comes to surgeries. You've got 95% technical error and 5% that no matter how perfectly you do things, something's not going to heal right. Those are the patients that we're all going to have to collaborate on to figure out, is there something that we can modify, whether that's with hyperbaric oxygen or some cream or magic potion to make them heal better. And I mean, we just can't get to that next step, which is so necessary, until we just cover the basics, where we don't have 1 out of 5 patients with distal hypospadias in the entire country of the Netherlands that have complications. We got to get to that 5% and then hone in on those. And so I think that's hopefully where we're headed. So the answer is clearly yes, but that should be the very last thing in your mind when you see a patient with a complication. Because if it's the first thing that you go to, well, this patient just has wound healing problems, right, you're not going to maybe take the technical step that your patient really needs.
So another person comments that, we don't have simulators for hypospadias, and that's true. We do just have live training, but that doesn't mean that we can't learn from that kind of example. And we're not really talking today about exactly, step by step how you teach hypospadias, for example, to a trainee. But that's in our article that we talked about, that we didn't have a learning curve. The whole genesis of that was the fact that when we were at the university and I was teaching fellows hypospadias, it was my practice, the way I did it, was I did almost the entire surgery and they assisted, and I would let them do bits and pieces over the course of their clinical year, but never did any of them ever do a complete from beginning to end repair. So, because this is how we do things, there came a point where I mentioned to her, or she mentioned to me, I wonder if the way I'm teaching is working. I mean, you could be critical and say, well, how will they know they're doing it right if you don't let them do it? And so that was the reason that she did the study, was to find out, did the way I teach work? And so the point is that by emphasizing, by showing the same thing over and over and over, they all learn to do it. They all learn to do it. There were some steps that some of them never did in the year, but when they went out, they could do it. So we don't have to have simulators. What we have to have is more consistent instruction. And that's why when we talk about tip repair, we're going to spend time to go through each individual step and talk exactly how we do it, because we have a low complication rate. That's the whole point.
And that doesn't mean that we're the only way that you can do it. But if you're going to make some sort of technical modification, which, oh my gosh, I can't tell you how many times we've read surgeons saying, well, the modified this or the modified that. Okay, fine. If it makes you feel good, modify it. But if you're going to modify it, then you need to prove that your modification is at least as good, if not better. And then if it's better, we think that the onus is now on you to say, we made this technical modification and we brought the complication rate from here down to here, because it behooves all of us to get better. And why should we all have to learn it individually with a learning curve of 300 cases in an entire career until we finally figure out how to incise the plate deeply enough because we never bothered to watch other surgeons? I mean, we can do better than that. And so I think that, you know, it's important in terms of not really having the simulator aspect, but I think the converse to that is to say, if you've seen it a number of times done the correct way, that you can achieve that. Yeah. And like all of us learned with surgery, we would watch somebody sew somebody's skin closed and think, okay, that looks pretty easy. And then when they hand you the needle to do it the first time as a medical student or a young resident, you remember how you were shaking and how difficult it was, and your skin closure looked nothing like anybody, you know, your faculties did. But then you realized, okay, I wasn't really watching exactly where that needle went or exactly how they loaded the needle. And so that going back and forth with those periodic reviews of things, periodically watching a surgical video or having discussions like this, it's the perfect opportunity.
Which is why our YouTube channel also has surgical videos of us doing the operation, so you can look at how we do it and compare to how you do it. And we are about to change out our lights and camera in our operating room, so we're anticipating more of those videos in the near future. And then somebody is asking about on the page where we listed technical errors, one of them was epithelial stitching. And so I'm going to say, yes, epithelial stitching is a technical error in certain ways, and we're going to talk about that next time, so you can, you know, wait and find out about that.
Okay, and I guess there were some questions. Some people are putting questions on the chat. Some people are putting questions on the question and answer, and so, you know, that makes it a little bit tricky in terms of not all of y'all can see some of the questions that we're getting on the chat because it's just something that us panelists have. So she can open that up if need be, and we'll try to make that more clear for some of the next ones. We've got a few more messages. Let's see.
So somebody is just commenting on the, you know, it's frustrating as a surgeon when sometimes things go beautifully and you're not sure, well, how did that happen? And sometimes things go terrible and you're not sure how that happened. And again, we just want to make the point over and over that the key is looking at your results. And we're not going to always understand why something went wrong that we think we did in the same way. But we're going to look at ourselves not on one case. We're going to look at ourselves as a group. This is getting a little bit outside what we're going to talk about, but I'm just going to tell you this. All of you've had the Expedius patients had a complication when they came back for follow-up that day. Everyone was perfect. Everybody was happy. This was a good day. And then there's other days when you go in, it's like, wow, every patient I operated on is back with a complication. Well, that's not really what happened. They just happened to cluster at that time. That's the reason that keeping your data like we do is so helpful in so many ways. And one of the best ways is realizing that when you have one of those days where just numbers through a bunch of patients with complications, you don't walk out the door with your head hanging down going, I don't know how to fix hypospadias. You know that overall your complication rate is 8%. You just happen to see the 8% all today. And that's the whole point. But you won't know this. You won't know if you're until you look. And when you look, you'll see, I need to get better. And then you may not be sure what you're doing wrong. Contact us, look at our video, email us, come visit us. When workshops start again, come to a workshop. I mean, there are so many opportunities to learn, and we're trying to give every answer we can to help folks to get better, because clearly that's to the good of all of our patients. So thank everybody for joining us. I think that'll conclude it for today. Again, this will be uploaded onto YouTube. Spread the word to other people if you like this, so that they can, sign into or look at YouTube.
And you can always join our hypospadiology group and give us some ideas for things that you really are struggling with and would like us to address.
All right. So we'll see y'all again in a month. Bye-bye now.